This is the second of our Euromigos Goes to Hollywood videos that we're making in Monty's backyard. Monty's not here. I think he's gone to get coffee or a beer if we're lucky. We're going to talk about upper tract urothelial cancer, and we're going to talk about it a little bit in the context of neoadjuvant and adjuvant therapy. As it currently stands, I think it's fair to say that there was a big study called POUT, and that was a randomized trial out of the UK. Patients were given either best supportive care or adjuvant gem-cis or gem-carbo, and in that trial that was published in The Lancet, there was a significant disease-free survival advantage. The study was stopped a little bit early. It wasn't a huge study, ended up being about 300 patients, and we never hit OS, although the OS hazard ratio was 0.5, 0.6 is trending in the right direction, but not statistically significant, never got there, which is a problem. You might remember Cora Sternberg's adjuvant chemotherapy study, almost identical results as I interpreted it. And so we've got this sort of issue with adjuvant chemotherapy that's never quite hit that survival advantage. And so it's never really been adopted in the same way as neoadjuvant chemotherapy, and I guess that also applies. But POUT's got the most robust data, included a carboplatin cohort of patients as well as cisplatin. And Joachim Bellman and other people say, well, there's a bit, those aren't really significant either. So the European guidelines don't recommend to include the carboplatin because of all the problems with perioperative carboplatin we've shown before. So there's lots of uncertainty, but it's fair to say I think it's the most robust data we have in this setting. And then more recently in the adjuvant setting, we've seen nivolumab, and that's in urothelial cancer, both upper tract and bladder. And the nivolumab data we know when you combine those two populations together was statistically significant progression-free survival advantage without seeing OS yet, but with no benefit in this upper tract group. And we know the biology of the upper tract patients is a bit different. The tumor mutational burden is a bit lower. I think there is more FGFR mutations. There's also less immune infiltration, more luminal cancers in that group. So the biology is a tiny bit different. So you can understand why there may be differences between the two. Immune therapy may not be working as well in that group. And of course, in the atezolizumab study, we know that was a negative trial as well, but it showed the same trend. In fact, the hazard ratio in the upper tract was 1.2. So overall, it's fair to say at the moment that there isn't much evidence, or we're going to hear that evidence in a second, there's not much randomized evidence for neoadjuvant therapy in the upper tract disease. There are these two adjuvant studies, immune therapy and chemotherapy, and the chemotherapy data, in my opinion, looks more robust. And so I think that's the standard of care. But you're going to talk about two studies in the neoadjuvant setting, a recent Coleman paper in JCO with split-dose gem-cis and also a dose-10-10-back study.
Yeah, thanks, Tom, for kind of framing that. You know, I think when we look back over the last 30 years, we hadn't seen any meaningful change in cancer outcomes for patients with upper tract disease. It became obvious that surgery alone wasn't going to be sufficient. The first suggestions, in my opinion, came from MD Anderson, where they had retrospective reviews of patients that received neoadjuvant chemo with downstaging. The next stage was a survival benefit. And then, in my opinion, it's been really exciting to see these two studies, one through ECOG and one led by Jonathan Coleman at Memorial Sloan Kettering, looking at neoadjuvant. And I think particularly for upper tract, it becomes critical because once you've received nephroureterectomy, roughly 60% of the patients are not going to be eligible for adjuvant cisplatin-based chemotherapy. So the ECOG study, led by Vitaly Margulis, multi-institutional study with Jeannie Hoffman as well, they had about 60 patients receiving dose-dense MVAC. And the primary outcomes were pathological downstaging, and they met their pre-specified endpoints. And when compared to historical overall survival and disease-free survival rates, it was looking very promising. So I think that gave us our first hint, and actually there's a second phase coming through ECOG of dense MVAC plus durvalumab, which is open and accruing now, just to add on additional therapy. So I think that gave us our first kind of prospective, higher quality data. And then just recently, in the last several months, the Memorial Sloan Kettering group published their experience, about 57, 60 patients or so. Primary outcome was pathological downstaging, less than T2 disease. And I want to say 19% of patients had a complete response rate, which is, you know, impressive. And again, compared to historical controls, matched stage for stage, the survival is looking promising. So it's a rare disease. Obviously, randomized controlled trials can be done, as evidenced by POUT, but I think we're starting to get more and more data that suggests that neoadjuvant chemotherapy would be the standard of care prior to people becoming ineligible and receiving inferior regimens like carboplatin.
So I want to ask all of you, I don't see a lot of upper tract. I mean, so do you think, we just had this discussion about non-clear cell with the same issue. It's a rare disease, we have single arm studies, the data's weak. A new patient comes in who has upper tract disease. Are you routinely giving neoadjuvant therapy? And if so, what regimen? Maybe, go ahead.
So actually you have to trust your surgeon or your referring urologist that they offer you the right staging, because we know to figure out if it's T2 disease or if it's really high grade, it's the key. So if we really think it's high grade T2, then yes, we do split dose cis-gem, or actually we do full dose if they have good kidney function because both kidneys are in place.
But gem-cis.
Yeah.
And Alexandra, because you haven't got tissue, some people use urine cytology. Do you need tissue before you would embark on that?
Usually I would like to have tissue before, or again have the urologist that they will do the ureteroscopy. Oftentimes they send me photos and I see what they see, and we agree on who should get neoadjuvant. Actually, when we have tissue, we look for Lynch, because that may change how you decide about immunotherapy afterwards or even pre-operatively.
Okay. And who are you giving? Are you giving anyone in adjuvant nivolumab?
No. I don't give everybody adjuvant. I try to give neoadjuvant cis-gem.
You give neoadjuvant chemotherapy. Are you giving adjuvant immune therapy? And if so, to whom?
So if patients look frail and I'm worried if they have recurrence, there will be a hard time getting therapy then. I discuss about adjuvant immunotherapy, because I know you don't believe in OS, but I think disease-free survival is not a bad endpoint for someone who is 80, 90.
Do you test for PD-L1 or no?
I don't have the information on when I decide.
Okay.
I try to get it before we start treatment, but again, if someone has disease, also our surgeons remove also lymph nodes, so if you know that they have node-positive disease, if we send for ctDNA, you have your Tempus data and Atera data, you know who is gonna recur or not. So
and you'd be obviously more likely to use Nevo in those settings.
Yes, correct.
Sure. Aditya, what's your practice?
Yeah, I completely agree, and I think it's important to discuss these in multidisciplinary cases. The staging's the crux of the matter here. If you have an infiltrative mass, positive cytology, and you're in conjunction with your medical oncologist, there's no need to necessarily do a ureteroscopy under anesthesia, put up a stent, increase your risk of lower tract seeding, for instance. Percutaneous biopsies, they were historically thought to seed the tracts. I think there's been plenty of data that suggests that those can be safely obtained. So, I think it's case by case. If you treated everybody with high grade cytology only, you're going to overtreat 60%. So we're getting better, I think, with imaging and looking at the cytology, looking at the imaging, looking at the features of the tumor. If you do a ureteroscopy, is it papillary, is it sessile, is there hydro? Are there any suggestion of infiltrative disease characteristics or nodes? Those are patients that are, we're really kind of pushing for neoadjuvant chemotherapy, or if they've got underlying kidney disease where you're worried about them being eligible for adjuvant therapy on the back end.
I think it's reasonable just to give adjuvant chemotherapy. And it's reasonable for the surgical team to go in, do a good operation, and give adjuvant chemotherapy.
Even though you may compromise your ability to give cisplatin in that setting.
Even though. With a randomized trial, it's a randomized trial, that's the one we have.
Right, but those subsets of cis and carbo were very different, and I know they're subsets, but they're pretty clearly different.
Joachim thinks so, but the MRC statisticians feel very differently. It was only a subset of a handful of carboplatin patients. The question, which I think is really important, which I think you made correctly, is that you are going to lose some patients who are not going to be able to get that cisplatin-based chemotherapy. So if you do not believe in carboplatin at all, then that's a more hazardous approach. But it's difficult to be driven by relatively small single-arm data. Having said that, the landmark analysis of those two trials do look really impressive. So it's a conundrum. I'm not a great believer in single-agent immune therapy in PD-L1 positives or in the ITT upper tract population. With those two trials, both of those subsets look pretty negative to me. So
you wouldn't give adjuvant Nevo to anyone?
I wouldn't currently be doing that, no.
We really try to pass the message to the urologist before you touch the patient, let us talk to them. And I mean, we're successful doing that in our institution, but I think that should be the message across the board, that let the oncologist tell the patient what cisplatin means, what carboplatin means, how patients are gonna be healthy-wise to be able to get treatment before or after a surgery. And I think patient has to agree or disagree if someone says I'm not going to get chemo no matter what, it doesn't matter. But if patients are open to get the most aggressive approach, treating with 2 kidneys is better than treating with 1.
I think to your point, there's a lot to consider before taking the first step.
Yeah.
Right. So you better get everyone involved.
Once you've done the operation, it's hard to go back. I think that's fair. We've had a great time on Monty's porch without him. Thank you very much. I hope you enjoyed it.